Hello and welcome to Megan Spotlight series. We are excited to launch the first in a series of newly initiated spotlights which focus on topics, discussions, research and future possibilities utilizing MEG in treatment of patients diagnosed with neurological disorders. Megan invited a selection of customers, key opinion leaders and MEG experts to share their knowledge, give insight into their work and achievements, as well as ongoing research projects and initiatives. Our first spotlight guest today is Dr. Stefan Ramp, who's been working and involved with MEG and EEG for about 20 years. He's currently the chair of the Magnetoencephalography Lab at the University Hospital Erlangen in Germany. Hello, Stefan, and thank you for joining us today.
Hi, Gabrielle.
Stefan, your research has included diverse topics such as MEG, surface and invasive EEG, as well as MRI analysis. You also published a study, Magnetoencephalography for epileptic focus localization in a series of 1,000 cases in 2019, which is published in Brain, the Journal of Neurology. An incredible selection and achievements there. Let's start with the most basic question to help our audience further understand MEG technology utilized for epilepsy patients, your field of expertise, of course. What medical problems does MEG technology solve for your patients? And how does data retrieved from MEG technology help you during diagnosis of a patient?
So we use MEG for planning of epilepsy surgery and invasive recordings in patients with pharmacoresistant focal epilepsies. So especially the very complex cases, I think, benefit a lot from MEG because we are actually able to nicely image the epileptic activity. We also use MEG for functional mapping. So we basically look for areas that are related to important brain networks that are responsible for, let's say, language, motor, somatosensory function, and so on. MEG has the advantage that it's not sensitive to changes of the anatomy. So if you have a patient that actually has a large lesion or previous surgery or just very complex structural alterations, complex anatomy, then MEG will still give you a very, very nice undistorted view on the cortical brain activity. We usually also combine it with simultaneous EEG, which actually gives us a very nice comprehensive picture of the brain activity that's going on. So we don't do MEG on every single patient. We are usually restricting ourselves to the more complex cases. And I think MEG makes a very, very large difference in especially these patients. So this is part of our clinical routine. We've been using it for many years now, 3 decades. Not actually myself, but I started, as you said earlier, about, I guess about 20 years ago. I think I'm getting old, which you can probably also see with my gray hair. We also collected a lot of evidence on the actual value of this technique. And as you mentioned, we summarized the results in about 1,000 cases. So that's all of the cases that we had investigated for pre-surgical evaluation over the past, I think, 3 decades. And I think the results are quite nice and underline the clinical value of this method.
So can MEG data prove that a diagnosis or treatment needs to be changed for a patient?
I think it does, because what MEG can actually give you in addition to the remaining pre-surgical evaluation is further information on the focus localization. And there are also studies that investigate whether or not this additional information actually influences patient management and post-surgical outcome. Basically, all of these studies show that MEG provides additional information in about 1/3 of those complex cases, where it really changes the therapeutic or diagnostic approach. So, for example, MEG can actually influence how many electrodes are implanted for invasive EEG, what the coverage is. It makes sure that you also cover areas that show epileptic activity. And in some cases, just with MEG recordings and imaging and EEG and the remaining pre-surgical evaluation modalities, of course, many patients can also just go ahead directly to surgery. And also in the remaining, we saw that MEG actually helps us to resect the area that then generates the seizures. And if you resect it, you actually have seizure freedom for the patient also in the long term. Then on the other hand, sometimes you have patients that have epileptic activity in the vicinity of functional areas. And in these cases, it's also important to consider whether or not you have a functional deficit after epilepsy surgery. So in these cases, it might actually happen that since the MEG localizations are overlapping with essential functional cortex, that you would actually advise the patient not to go ahead to epilepsy surgery, or at least have a very in-depth evaluation of these spatial relationships. Because otherwise you have functional deficits after surgery, might not even be seizure-free. And that's, I think, another approach that MEG has, that it can also counsel to be more conservative. So for example, also in patients with multifocal and diffuse epilepsy, where you can actually not really see where the seizures start. So the probability that the patient becomes seizure-free after epilepsy surgery is rather limited in those cases.
For us, of course, it's really interesting to know where and how have you used MEGAN data in your clinical role in Germany, and how has that data aided you in suggesting next steps for patient, and what's been the outcome?
So that's a good question, because as you might know, we actually don't have a MEGAN system. However, we collaborate with a number of institutions and hospitals in Germany. So for example, with the Max Planck Institute in Leipzig, and also with the University Hospital in Magdeburg, and they both actually have a MEGAN system. And in some cases, they make recordings from their patients. Sometimes we send patients there and have them actually do recordings for us, because the patient lives actually closer to that area, or is also a patient that comes from the University Hospital in Halle. That's actually my second job. And that's about probably an hour to the MEG lab in either Magdeburg or Leipzig. So we also send patients there. So my experience with the MEGAN data is actually pretty good. What I probably like most about it is that it's rather robust against noise, because of the different approaches that MEGAN has implemented in their software. So when you, for example, have patients with a vagal nerve stimulator or other implants that actually would cause rather strong magnetic artifacts, then these approaches allow you to get rid of most of that noise and still get a very nice clinical finding that could potentially influence the management of this patient. So just for example, we had one patient in Halle with a cavernoma very close to language-related areas, and we sent the patient to the Max Planck Institute in Leipzig and did a recording on both spontaneous activity, but also for mapping of language function. And that actually nicely showed the relationship of these two. And fortunately, we were actually able to do epilepsy surgery with a very nice outcome. So the patient was seizure-free. We got rid of the cavernoma, and the patient did not have any problems with language function. I would say that, or I know that such approaches of noise reduction software are also available, for example, in a number of open source solutions. So for example, Brainstorm or Fieldtrip. But the issue is always that we are actually not supposed to be using this for clinical applications, for legal aspects, certainly also to make sure that we have valid results. And since MEGAN provides this as part of the clinical software, that simplifies the life quite a bit. And in comparison, our system does not allow us to do this. So I'm quite happy that we have these collaborations and that we can actually send these specific patients.
Well, that's good to know. So how do you feel about MEG technology research for further clinical applications? Always a topic.
So there's quite a bit of research going on. It has been going on for some years to apply MEG and specifically also source localization for other diseases. I think what probably is most promising is application in TBI to evaluate or get an objective marker for the subjective complaints in patients that suffer from TBI. In addition, for example, also in tinnitus, you have the very same application. You also have the subjective perception of these tinnitus-like tones. And it's really hard from someone that evaluates the patient, how that feels, how the intensity is, whether or not there really is this percept or not. And MEG might actually enable us to get an objective access to the subjective perception. And beyond that, there's very, very nice work that evaluates the use of MEG to predict the development of mild cognitive impairment over a number of years that might actually also counsel patients in the future, might help to develop therapy and many more applications in this regard.
Certainly a topic we can have another spotlight on, I would think. So one other important aspect we wanted to touch on are the patients themselves. How important do you think it is to educate the patients community about MEG technology, and how have you been involved in working with patients' organizations?
Now, that's a simple question because the easy answer is it's very important. The whole truth is a little bit more complex because I think that MEG is not very well known to patients. If I talk to patients, they certainly know what an MRI is, what an EEG is, because they usually already underwent quite a number of investigations with these techniques. But most of them have actually never heard about MEG or magnetoencephalography, right? So it's a long word. Patients usually don't read about it, don't hear about it. And I think that's a problem because many of those patients could actually benefit from having an MEG as an additional modality in pre-surgical evaluation. And I have to admit, we're also not really good in communicating the value of MEG outside of our bubble, probably. So I'm trying to work together with patients and specifically also with patient representatives. One example would be a current project that we are working on with the ILAE and the IFCN right now, where we try to summarize current evidence that's available on MEG and EEG-based source analysis. And our goal is to work on clinical practice guidelines to better show what type of evidence is available for these techniques and how these techniques can help us in clinical practice. But in addition to that, we also will try to actually translate these scientific manuscripts that we are working on into a form that's more understandable to patients, but also certainly to physicians outside of our field. Because usually the patient, the first guy that a patient with epilepsy sees, of course, is his or her family doctor. And usually they don't know anything about MEG, and we probably have to change this to better inform them and also engage into discussions with patients, with physicians, to communicate what MEG is able to do for these patients and how it can improve their situation and the epilepsy that they've been suffering from for some decades in some cases.
This is actually certainly something Megan wants to get involved in as part of their roadmap as well, and we're putting plans in place to regularly roll out helpful marketing material or material on videos explaining MEG in a more simplified way to the patients. Maybe this is something that we can sort of collaborate on over time. Thank you very much for your time today. We really appreciate it. It's been very interesting to find out about the way you work with MEG and with Megan as well. And we would really like to see more of these spotlights, and we'd like to invite you for further ones, maybe discussion panels in the future. We've come to the end of our spotlight, and I'm very excited to run a series of these in different styles. So please stay tuned and follow us on social media, all our listeners and audience right now. If you'd like to take part, please wait till the end of this feature and we'll have all the contact details on there. And follow us on social media for more information.